Good afternoon, friends. Those people who had lunch, please be seated in the hall because this is a very important, interesting session where we are going to talk about tough situations, difficult scenarios, how to do proper cataract surgery in such cases, and we have very prominent speakers and panelists to discuss on those cases. I am Dr. Jeevan Tityal. As a chairperson, I'm going to invite Nitin Balakrishnan as a co-chairperson, Dr. B.P. Kashyap as a convener, sir, please come, and Dr. Satyamurthy, I think they are going to join us subsequently, and moderator Dr. Gaurav Luthra. So I'll take the opportunity to do everything myself except for convener Dr. Kashyap here. Let's begin with the first topic, that's phaco in adverse situation, a perspective. Dr. Sunil, please come.
At the outset, first let me thank both APOS and AIOS for giving me this opportunity. It's been a great pleasure coming here, and you don't have to listen to me, it's all recorded in there. So I will just start the video. You have the voice on, please. Excuse me. Perspective, and since our patients present very late with lot of comorbidity, I will use a series of clinically common presentations and some individual tough cases. When they present with this hard and brittle cataract, it is pretty easy because you can use any vertical chopping method and handle the case. However, if they present with these diabetic, hard and leathery cataracts with the unyielding backbone, I sometimes flip the nucleus over, attack that central attachment with my phaco tip. But I think this maneuver should be done by experienced surgeons. The soft cataract, as you all know, is an oxymoron. The easiest way to handle it is to prolapse it and eat it, or you use the horizontal chop with this long tip ball chopper, as has been shown to me by Nato and Alex. I also use this ball chopper for mechanical cleaving in the posterior nodal cataract. Kindly concentrate only on the central videos, and this is the B-Hex ring from Suven Bhattacharjee. A fantastic device, gives you a hexagonal pupil of 5 mm, very easy to insert, very easy to remove, and look at the fantastic pupil post-op. And in the intumescent cataract, there are many ways to handle it to avert the Argentine flag. I, however, favor the automated decompression, wherein I attach my aspirating needle to the aspiration line of my phaco machine and decompress the lens. You can use any gauge, but I prefer the 24 gauge. And even if you get the Argentine flag, it's no big deal. You can still handle it, as is shown in this case. Down here, I put in a 3-piece lens, of course. And these are cases of therapeutic keratoplasty where I have done phaco. The one on the left is a phacomorphic glaucoma, which presented post-therapeutic keratoplasty. I'm doing a combined surgery. The one on the right is a post-patch graft. I'm doing a phaco in a very advanced cataract, and this case got a very good result. You can see it got only a 3 diopter astigmatism, which I will take any day. And these are other cases of corneal problems, and this is a keratoglobus, this is a case of severe corneal opacity, and this is a post-crescentic graft in a Moran's ulcer, and I had to use tissue glue during the procedure. This is a very interesting case. He had an injury 6 years ago, and he had a sudden drop of vision over the past 1 month. On gonioscopy, we found that he had an intraocular foreign body, a retained intraocular foreign body. So we de-epithelialized the cornea, went ahead, tamponaded that foreign body with viscoelastic and removed it with a micrograsper. And he is doing pretty well, but probably I did a phaco, of course, after that, and he would probably need a graft later on. This is another difficult case. In fact, he presented to us with the fungal ulcer and a phacolytic glaucoma. It took us 1 month to heal this fungal ulcer before I attempted the phaco on this case, and as you can see, it was a very difficult surgery. Did a combined procedure, very difficult to get the rhexis. Somehow cut it, got a sizable rhexis, dislocated the nucleus into the antechamber, used an IOL, a hydrophilic IOL, as a scaffold, handled the nucleus. It was a very hard nucleus, as you can see. Thought there was cortex there, dislocated the IOL into the antechamber, realized the cortex was in the vitreous, put in a CTR, relocated the IOL into the posterior chamber, put in some triamcinolone, and post-op he is doing very well. And these are cases of phacolytic glaucoma wherein I use a IOL as a scaffold when the bag is so loose. And this is commonly done, nothing much to talk about. And these are cases of phacomorphic glaucoma. The main thing in these cases is you got to get a rhexis after decompressing the lens, and after that the handling of the cataract is pretty simple. And these are unanticipated subluxations of the lens. Herein I usually, after hydrodissection, put in a CTR for horizontal stability, put in iris hooks at the rhexis edge for vertical stability. After that it becomes like a regular case and you can complete phaco very easily. And these are what I would call sins of the others, wherein these are faulty wounds referred to me by colleagues. I repair the wounds and then go ahead and do the phaco in them. This is a very, very bad wound. As you can see, this was an inadvertent deep dissection during an SICS, and this was done at the same sitting. This was done the next day, and the cases do pretty well actually. And this is a very rare case, the only case that I have seen of a hexagonal keratotomy. He also had a narrow angle glaucoma, he had YAG PIs, he had shallow ACs, very dense asteroid hyalosis, very tough to manage, but did get a good result in the end. And these are my sins. This is a case of retinitis pigmentosa, wherein I did a phaco 1 year ago and he came back with a severe capsular phimosis, and I had to use a bimanual technique to go ahead and cut that extremely thick anterior capsule. But he did improve from 5 meters to 612. And this is a case that I had done almost 10 years ago, a coloboma lens, wherein I put in a CTR in this lady. She did very well actually. Till 7 years later, she came back with this inferior subluxation of the lens. And I had to hook it superiorly. I had to hook that CTR complex superiorly to the sclera with these Prolene sutures. And as you can see, it was a good result. And these are some patient factors. This is a case which presented with gross proptosis, probably an IG4 disease. He had been having it for 12 years. He just wanted us to take out his cataract, and that's exactly what we did. And this is something that you will commonly see, these patients with head nodding, and you just ignore the head nodding and go ahead with the phaco and all goes well. And this is something I'd like to talk about. This is a patient who was referred to me as a psychotic patient. We put her under GA and did both the eyes, both were hypermature cataracts, and she got a very good result. And can you believe it, 4 hours later when we pulled out the pad, her psychosis disappeared. So all along it was just a sensory cause. And these are cases of traumatic cataract with their varied presentations. And as long as you plan well and stay ahead of the game, most of these cases you can handle and give pretty good results eventually. Thank you so much. I will be talking on phaco in adverse situations from the Indian perspective, and since our patients present very late.
Thank you, Dr. Sunil. Wonderful collection of cases. He showed almost every range of difficult scenario possible in cataract surgery, and he is a high volume and very experienced surgeon. And one thought, during presentation came to me, like people talk about nowadays, bilateral simultaneous surgery, world over, and the situation you talked about has a definite indication for doing bilateral simultaneous surgery, especially patients suffering from psychosis or patients suffering from a disorder where you can't do local anesthesia surgery, and giving GA to older patients is also difficult. So maybe that's the one indication for doing a bilateral simultaneous surgery in our scenario. Very nice. We'll have a discussion subsequently, sir. We can invite, I think Dr. Nitin is not here. Dr. Niruban is here. Niruban, he's there. So he's going to talk about tail of subluxation cataract, various methods of management. I think subluxation is a one difficult scenario. We saw one case from Dr. Sunil also, and they always have a difficult challenges. What you see on the examination or under microscope, under dilatation, slit lamp is totally different than what actually you see under the operating microscope. One patient lying flat and to inject viscoelastic, then you see the subluxation is much bigger than what you thought under pupillary dilatation. When you try to do a rexis, then you realize the intact capsule is very laxed and elastic. Those things are very, very challenging, and to come out successfully is the art which we have to learn. Doctor, I think he's going to take us through Niruban, the entire range of subluxation cataracts.
Good afternoon and all. I am Dr. Niruban, Assistant Professor and in charge Department of Ophthalmology at GPMR Karaikal. GPMR Karaikal is a newer sister institute of GPMR Pondicherry. So this particular case which I am showing is a 60-year-old male with unilateral subluxation. This patient did not have any sign of subluxation in the OPD, just that anterior chamber was shallow. So only the presence of a shallow anterior chamber, unilateral shallow anterior chamber, was the reason which I suspected subluxation in this patient. So as you can see, with a very little amount of visco being injected into the eye, you can see most of the visco being egressed out. So that's shallow the anterior chamber was. And the second aspect is on making the rexis. So when the needle is placed on the anterior lens capsule, you can see the folds on the anterior lens capsule, and doing the rexis gets difficult in cases of subluxated cataracts. So you need to move through the side port as well as the main port to go through the or to perform the rexis. And in this patient, I did not use trypan blue as well, so I was using the retinal glow only to perform the rexis. So once rexis is done, the next step being hydrodissection. Already the anterior chamber is shallow, so once the hydrodissection is started, you can see the iris coming out, and there was repeated iris prolapse, making the surgery even more difficult. And the mydriasis also was poor following this, so the size of the pupil reduced to almost 4 or 5 millimeters. And I did make sure that the lens is fairly rotating well into inside the back before I could proceed with phacoemulsification. Once I am sure that hydrodissection is complete, I inject very little viscoelastic and then proceed with phaco. So with phaco, we can use techniques wherein the manipulation on the lens is less.
Niruban, can you stop here?
Yes, sir.
For a second, let's have a discussion up
Yes,
to this point, because this is a very challenging scenario. Satya, how would you approach this patient where you suspected the subluxation on the table, and the way the case went on? What would have been your approach? Use a mic. You have a mic? Yeah.
No, one thing is iris kept on collapsing. So what came to my mind is probably the fluid has gone through the zonal dehiscence and the vitreous pressure has increased. So that is one thing.
So
maybe I would have avoided pushing fluid over the anterior capsule. And second thing is I would have definitely put the capsular hooks or iris hooks and then go ahead with the surgery, rather than waiting for this thing to happen, something else to happen.
Dr. Kashyap?
I would have made a lifeline, that is a pars plana, trocar canula, and then do a little bit of vitrectomy if the AC was becoming so shallow, and then I would have taken the help of the trypan blue, and probably if the hooks were required, I would have done that.
Okay. Dr. Sunil, one comment?
Yeah, definitely you have to don't manipulate when the iris is prolapsing that much. Don't manipulate through the same. Manipulate from somewhere else, put it in. That is one thing. The other thing is either you put in some midriacane or phenocaine or something. Handle the iris. Put in the hooks. Don't continue with the phaco with the iris keeping on coming out like that and shutting down on you, because you are going to increase your chances of complications like anything. Once you put in the hooks and the
No, I think Niruban, was doing a case, and things are getting more difficult and difficult.
This was a
Yeah.
topical phacoemulsification, so
Yeah.
I
No,
avoided
think
iris hook.
Few important points which people have to understand if you have a subluxation as a suspect. The first thing is, to have a very nice visibility, dilate the pupil well, and stain the capsule in a more darker way so that you can see the rhexis thing properly. And subsequently also you may have to handle the rhexis by hooking the rhexis with the capsular hooks, or you want to put some other devices, so rhexis will be visible. So that should be done before the hydro procedure, so that your visibility of a rhexis margin becomes not that clear once you do hydro dissection. And rightly said, the pupil expansion would have been better to manage the case in a more simplified manner. And with the repeated iris getting handled, two hooks would have also created a nice.
When 4 or 5 hooks are placed,
Yes.
the
Let's see how the case goes
Yeah.
now. Niruban?
yes, sir. So proceeded with phacoemulsification. I personally don't prefer inserting CTR without removing before removing the lens. So I did proceed with phacoemulsification, and so the main technique which you have to use for phacoemulsification is the one which you don't keep on trenching, so that you increase the zonal dialysis. So minimize trenching. You can chop it, and you can do a direct chop and do the rest of the phaco. So once the phaco is done, I did attempt I&A. Until now, I did not see any sign of a zonal dialysis. It seems apparently okay, so I did attempt irrigation and aspiration, and you see what happens. So the bag is getting folded, so I stop there, and then I insert a CTR. And when the CTR is being injected also, you can see that the bag is very loose, and maybe half of the CTR, when it goes inside the bag, only then you see that the bag gets stabilized, as you see now. Yeah, so now the bag is it seems stable. So the CTR is inside the bag, and I switch over to a Simcoe instead of IA cannula, because there is controlled irrigation aspiration of the cortical matter. So once the IA is done, I inject the intraocular lens into the bag, and here again careful maneuvers are to be used, wherein there is a controlled release of the IOL rather than a sudden release, and dialing it into the bag should also be a very gentle maneuver. You just place the haptic in the bag rather than dialing it, and the final irrigation aspiration of the viscoelastic is also done by the Simcoe cannula. So these are some important points to be followed during subluxation, operating on a subluxation of lens. And this is the 1 week post-operative picture of this patient. There is some minimal edema over the section, and vision is 6/9. This is another case, unilateral subluxated lens. This patient underwent trauma to her eye with a broomstick, and you can see almost 270 degrees of subluxation here, and the lens is grossly shaking inside the eye. So in such cases, I would prefer to do an SICS, do an ICC, and then plan for a scleral fixation of IOL rather than going ahead with phaco. So an ICC was done to remove the IOL with the capsular bag, and I use a 3-piece IOL and suture it or anchor it to the sclera using the X-knit technique. since the subluxation was more, around 270 degrees, I would rather go ahead with ICC in such cases rather than Phaco. This is the picture after the surgery. Thank you.
Wonderful, Niruvan.
Thank you, sir.
What about the retrofixation of IOLs in such cases?
Yes,
you
sir.
practice
That
that
is another
also?
option. That is another option wherein after ICC, iris claw lens also can be placed.
How long is the experience of yours in terms of retrofixation IOLs?
There was one more surgery which I did on using a retrofixation of lens. Following, it was a primary sitting only.
Okay.
ICC using an SACS tunnel and then retrofixation of lens.
Thank you, Niruvan. It was a very nice presentation. So he showed difficult scenarios. Sometimes like second case where you have such a huge subluxation, no point struggling to fix a bag and doing Phaco, and ultimately we will not be able to fix the entire bag in the proper area. Rather to do a simple SICH, take out the nucleus and lens, then put a fixation device of it. Let's go to the next speaker, Dr. Ansuman Goswami. I think he's not here. So we can Birinder Prasad Kashyap. Birinder Prasad. I knew BP Kashyap, Birinder Prasad. So sir is going to talk about demystifying CTRs. As you saw in this particular case, how to put a CTR, how to select CTRs, which are those cases, sizing, fixation, various things are there with CTR, and it is one device which should be there in your operating table most of the time, because bag subluxation can occur any time during your procedure also, even in normal cases sometimes. So CTR, if there, it's always handy. Yes, sir.
Hi, good afternoon, everybody. So we all know that the CTRs are required in our operation theater. It is used for many indications like subluxations and the zonal weakness, and if you find the zonal weakness per operative and all those. So you can put the CTR immediately after the rhexis, after the nuclear management, in between the nucleus management, before the IA, after IA, and probably many a times you put the CTR after IOL implantation. The Phaco surgery, because it's a closed chamber, it has advantages and easier to put the CTR, and it is little more tougher in cases of SICS because the incision is large. So I'll be discussing about putting the CTR, because you have seen CTR being put, the leading haptic, everybody is showing that okay, it's going to the bag, but the posterior rung, how it goes into the bag, that is very tricky. So you can put the CTR clockwise, you can put the CTR anti-clockwise, you can put the CTR only by forceps, that is the trailing ring, or you can take help of the forceps and the Sinskey hook. I'll be talking about the Sinskey hook and the forceps, and sometimes two Sinskey hooks. So you get the CTR, in many ways. You get a ring only. So you get a preloaded CTR. If they are preloaded, there are two types. Left side it opens left side, right side it opens the left and right side, and there are some which you load in the tube and then you inject. So those are kinds of CTR. So I'll be talking only about the ring only, the simple available ring without any preloaded or injectable. So can we have the sound, please? A case of subluxated cataract, CTR inserted clockwise, and the trailing ring of the CTR is pushed by the 25 gauge forceps in the bag. A mature cataract with high ILP, puncture is done, capsular dehiscence was seen only after IA, CTR inserted clockwise, and forceps used to push in the bag but slipped. Sinskey hook used to engage the ring and pushed it in the bag. The trailing of CTR was pushed by the Sinskey hook and the other Sinskey hook help the body of the CTR to get aligned in the bag, and the simple pressure on the body releases the Sinskey hook from the ring and the CTR goes in the bag. In SICS, preferably CTR should be inserted through the side port. The trailing ring left in the AC, and the Sinskey hook picks up the ring of CTR and pushes it in the bag, and the tap on the ring releases the Sinskey hook from the ring. A case of Cataract plus strab. After inserting the IOL, we found capsular dehiscence. CTR inserted through main incision. The forceps feed the ring to the Sinskey hook, and Sinskey hook guides the CTR in the bag, and the ring of the CTR is released from the Sinskey hook by a tap of the ring.
Takes it there and the tap.
A case of coloboma of uval tissue with a capsular dehiscence suspect at the colobomatous area. In this case, the trailing CTR ring is inserted in the bag by the forceps only. And the surgery is completed after SFT, pupilloplasty. After the cataract removal, capsular dehiscence was found. CTR is inserted and the ring of CTR slipped and lost in AC. Sinskey hook from side port fetches the ring and guides it to the capsular bag.
If you lose the ring behind the iris, you are in trouble.
Soft cataract with coloboma of iris. The capsule is stabilized by the hook, and the CTR is inserted before the whole cataract was removed. CTR inserted by the help of forceps only. And the surgery is completed with SFT pupilloplasty. A case of capsular dehiscence more than 90 degree. The forceps pushes the ring pushes the ring, and the hook from the side port, it guides the body of the CTR in the bag. And the CTR is checked by rotating for its position in the bag. So these were few tips I thought to give it to you. Thank you so much.
Any questions, sir?
Thank you, Dr. Kashyap, showing those difficult scenarios where CTR put in a different manner. Just one question to Dr. Satyamurthy. Do you use these, preloaded CTRs in your cases?
No, earlier I used to use this metallic injectors, CTR injectors, but because that visco used to get, so next cases I used to see a lot of visco coming out of the thing. So that's why now I used like what sir showed
Okay,
similarly.
it's, simple
I have no
manual
idea.
devices.
Yes,
You
sir.
know. Anybody uses injector system, preloaded CTR? Dr. Sunil?
I do use.
Okay.
I do use.
You find that comfortable, sir?
Yeah, it is. It's in certain situations. It's a lifesaver.
Yeah.
You know, sometimes it's of so much manipulation. You can just go ahead and inject it. That's it. And whenever you're doing it manually, you always support with the other hand, the CTR. Be very careful, otherwise you can lose it.
That is absolutely true. You have to make sure that your leading haptic is inside the bag, and that once you put it a little pressure towards the rexus margin, it should tent the rexus, so you know that your CTR is getting inside the rexus, inside the bag. Otherwise, it will go over the rexus and you'll not find it, and label it will go haywire. And once it goes in a circus area, very difficult to retrieve that. So
Dr.
make sure
Sunil,
it's in the bag.
Dr. Sunil, you put CTR in one case of PCR?
PCR, no, never.
Yeah, you should never put that. Yeah.
Never in
Okay.
PCR.
Okay.
So there was a video this time in APACRS where it was a best innovative video award to that person, where he devised the loading device where both the leading and the trailing eyelets could be injected inside the bag. So you don't have to really worry where this is going to open. So that was fantastic video I've seen, innovation by somebody. Maybe it will come in market very soon, where you have both the eyelets inside. First it goes like this, then you can do the second hand, it goes inside. So those preloading devices can be sometimes better, especially in a large subluxation, shallow chamber, upthrust. Things can be managed very effectively. So we have seen so many videos. CTR is a must sometimes in your operating, not in table. It should be in your operating area. Suppose you have something, you can easily put CTR and manage the bag. Thank you, Dr. Kashyap.
I had to check for 3-4 years of my surgery so I could find so many CTR cases. Thank you.
So we can invite Dr. Nasreen if she's here. Thank you being in this hall today. And I think post lunch sometimes it's very difficult for people to come in. But still, looking back, I was since morning I'm in this hall. So this is the largest gathering I've seen in this afternoon. Dr. Nasreen is going to talk about dancing cataract. We dance, but the cataract also sometimes dances.
Good evening. Someone is straightly. I will start with videos. Okay. Most of the times we see intraoperatively moving cataracts. Okay, this is NS4 cataract with phacodonosis. I started with phaco. It is moving extensively. I took CTR. CTR should be negotiated into posterior to capsular axis in a circular manner and in a horizontal manner. Otherwise, it may pierce the fornix of the capsular bag and will escape into the vitreous. I took 2 McPherson forceps and I am dialing trailing loop and completed the surgery and do cortical aspiration and implanting IOL. This is next case. This is a traumatic cataract with anterior capsular calcification. First I will check whether I go ahead with the phacoemulsification. If it is not possible, then only I put CTR. First insert, checking but whether it is going behind rexis or not. This is on McPherson forceps. It is going smoothly. Otherwise, I take 2 McPherson forces and stabilize one with one hand and negotiate with the other hand. And don't lose the trailing loop, otherwise it will be difficult to catch it again. This is one more case. How to play? It is not going, that's why I took help of dialer, engaging that leading loop. Now I am stabilizing with what McPherson forceps, and I am taking another one. But movement should be in a circular manner and horizontal manner, otherwise it will go posterior. To release it, I am taking help of another dialer. In this case, I kept CTR after completion of Phaco. This is little bit difficult, it may PSPC. Carefully we have to insert. Okay, thank you. Complications are postcapsular rupture, dislocation into vitreous, extension of dialysis. Sometimes removal of whole bag may happen. Thank you.
Thank you, Dr. Nasreen. Beautifully shown cataract surgery and CTR being implanted. Just for a clarification for the house, ma'am, what would be the indication for putting CTR before we do Phaco? Or sometimes people like to fix the bag with, the fixation devices by hooks, complete the Phaco, then put CTR subsequently. So what do you think the indication for putting CTR before we do Phaco in these cases?
Whenever I am facing difficulty by proceeding with the surgery, I am putting with when nucleus is there, sir. It is easier.
Okay.
Once we remove nucleus, there is the risk of postcapsular rent.
Once you inflate the bag with a viscoelastic, then it goes, easily inside this thing. The idea is once you put a CTR beforehand, sometimes, the cortical aspiration or epicortical cushion becomes very difficult to remove. It holds the, cortex behind the CTR.
Sir,
So
we are
becomes-
doing since 20
So,
years. And
so you may have to struggle sometimes, especially in a softer cataracts, because sometimes CTR might block. Then you have to pull these, cortex little tangentially to pull it. If you pull it like this,
no, we had to
it's going to pull the CTR also.
tangentially, sir. We had to.
So that is a little trick you like to know, and she brought out the cases beautifully, and towards the end she also gave a few points on a complication which can occur putting CTR, especially PC rupture, CTR opening into the sulcus, going backwards. So those things can be managed if you have a nice visible capsular excision margin, as she showed. Staining of capsule is very important to see CTR going right in the right direction. Beautiful surgery, ma'am. Thank you, Dr. Lassi. Any comments? Okay, let's go to the next speaker, which is Deepanjan Ghosh. Not here. Now we have our own Dr. Satyamurthy. Today, I think we are going to discuss this newer ways to fixing IOLs in the absence of capsular support. Dr. Satyamurthy.
Yes, sir. Yeah. Okay. Right. At the outset, I'd like to thank the organizers for giving me this opportunity. We have seen a lot of cases of subluxated cataracts, dancing cataracts, wherein we could insert CTRs and then some of place the PCAL, but still there are situations where you will have to manage without capsular support. So I would like to just discuss about the previous. I will not show the previous surgeries at all. Now the drawback with these polypropylene sutures are that tenoprolene, the tenopolypropylene suture is very commonly used, but it is prone to develop biodegradation. It's called semi-permanent suture. So after about 5 years, 10 years, we see the people coming back with IOL dislocation. Same thing with 90-polypropylene also. So because the material itself is like that, it can undergo biodegradation. So now this particular material which is used in cardiovascular surgery, this is made of expanded polytetrafluoroethylene, what we commonly call as Teflon, which is a permanent suture and inert. So I would like to show various, this is just before showing the videos, I want you people to see what exactly it is. And then we have customized the needle. See the previous one, the needle, it is a curved needle. Even though it is atraumatic, it goes through 21 or 20 gauge needles. So it's not possible to do without stitches. So that's why we customized a regular sewing needle. The top one what you are seeing is about 7.5 centimeters in length, which has got an eye. It's a regular sewing needle, the thinnest I could get. And so now I requested one surgical company, so they helped me to bring it down to 16 millimeters, 1.6 centimeters, with a tapering end, and that goes through 26 gauge needle. So this helps me to perform surgery with the 26 gauge needle itself. This is an aphakia where I am just performing the Hoffman's pocket. So once it is done on either side, the anterior vitrectomy is done, and then now the previous tunnel is open. AC is, eye was little soft after vitrectomy, that's why. So now using 26 gauge needle and using this customized needle, which is threaded with the Gore-Tex suture, so now it is brought out with a loop outside. Same thing is repeated on the other side. So now we have two loops on here, and then through the Hoffman pocket the suture was retrieved outside. And now using the regular skill fixation forceps and using this claw hitch knot or girth hitch knot. So the suture is fixed on either side, the loop is fixed on either side of the eyelet. This is repeated on the other side. And now the IOL is inserted just like regular IOL. After completing the knot goes into the Hoffman's pocket, and then eye remains very quiet because this particular material is known to be inert. So this is the end of the surgery. IOL is very well centered. Pupil is not exactly round because there is iridectomy performed during the primary surgery. That's why it looks little elongated. Now this is another surgery where this is a modified M1A technique. Instead of using the 26 gauge needle, this is 25 gauge trocar and cannula, which is inserted at 180 degrees apart, and then this is a regular hydrophobic 3-piece foldable lens from Johnson & Johnson. This is inserted completely into the antechamber. Now the cannula, trocar and cannula is removed, and using the ILM forceps and using this handshake technique, ILM forceps goes through this 25 gauge opening, scleral opening. One haptic is externalized. Similarly, the other haptic is also externalized. While external other haptic, surgeon holds this haptic so that it doesn't retrieve inside, and using this Canabrava technique, the haptic, the PMMA haptic is cauterized to create a flange, and that goes into the under the conjunctiva into the scleral. So this way the lens remains centered. So this is a slight modification, and this is another way of doing fixing the lens in the absence of capsular support. So here the at 90 degrees the cornea is marked, and then using AC maintainer, now I am sitting at on the temporal side, so about 1.75 millimeters from the surgical limbus, and then 2 millimeters on either side of the central point. So now using the same railroad technique, and the 26 gauge needle is passed at this point, and then it is brought out, and then it goes under the conjunctiva, and then exactly at 4 millimeters it is brought out. Same thing is repeated now. So now you have a suture which is like this, like a rectangle, and now same thing is repeated on the opposite side. So now you have a mesh which is created. We have a mesh created now, and regular PC like regular 3-piece lens is inserted like how we do in a regular capsular bag. And now one thing here is, now there are 2 loops, one above, 2 are above and 2 are just below that, and then the optic is captured between the superficial and the little deeper one, so that IOL remains centered. But all said and done, this is again polypropylene 90. So we tried with the customized last video, sir. Customized needle with 60 proline, and the same thing is done. A mesh is created where the central 4 millimeter is open. Now because the globe was collapsing, I had to put air, so same thing is repeated. And now here on one side I cut the suture little long, and then using the Canabrava technique, made the flange at the center and then put it under the conjunctiva. Here I have tried a tunnel, and now the whole thing goes under the tunnel, so that the suture knot doesn't get exposed. Now we have a mesh here, and then place the rigid 3-piece lens over the mesh, and then capture the optic between the superficial and the deeper portions of the mesh. Lens is very stable. Yeah, now that's another thank you very much, sir. So we are now trying with Gore-Tex suture, the same technique, because it remains permanent. See, in my opinion, scleral fixation is like plastic surgery, oculoplasty. You will have to use your this thing and then imagination, then you can sew this it. So thank you very much for your patient listening.
Dr. Satyamurthy, it was wonderful, seeing your videos. Very you can nicely demonstrating all these difficult surgeries per se. I think suturing, which we have been using nylon sutures, we have seen patient coming back to us with a total subluxation, sutures getting degraded, and the Gore-Tex suture is going to change the entire scenario. So that is important to have suture going to last for that longer period. Otherwise, nylon sutures within 10 years they lose their strength, and sometimes we have subluxation happening. And this mesh technique is beautiful, where you entangle the lens and by getting a sort of a capture happening in the tube. Very nice. It's like a bridging the lens in the eye. Thank you, Satyamurthy. I think we have some time. If I can show one of my video here, I take the opportunity to fulfilling the people missing today. Just for a younger people, we deal with a small pupil sometimes. This was a small pupil case. Normally, we like to do surgeries without manipulation. Though this was a rigid pupil around 3.5 millimeter, I thought I'll do a smaller rexus and do surgery without messing up with the pupillary plane here. So I was trying to do a rexus here. So I could succeed in doing around 3.5 millimeter rexus. Then I realized this was a case for toric implantation. So toric implantation is always difficult in small pupil because you can't see the edges. So I thought of doing hooks to expand the pupil. The classical teaching is to do 4 hooks. Here I am putting 6 hooks. The important thing here to learn, few things are very important for young people sitting here. The incision is posterior limbal. So once you inject the iris hook, they will be parallel to the iris. They won't tent the iris tissue. This is also important for subluxation, where trying to fix the bag. If you do a little anterior incision, that is tenting the bag, and you can tear the capsular access margin also. And same holds true for iris hooks also. You can see I'll put all the iris hooks inside first, then slowly one by one I'll retract the iris hook so that pupil is expanded uniformly without putting a lot of stress into the sphincter here. If you just pull one, the entire iris tissue come to one side. The pulling the second one, you can damage the sphincter here. And normally put 6 hooks nowadays. It gives a very nice hexagonal appearance as you have in various expanded devices. 4 hooks are good, but 6 are much better in making pupil very nice hexagonal appearance. You can see a beautiful hexagonal appearance. I'm staining the capsule again. You see that rexus was around round, very nice, around 3 millimeter. I'm trying to enlarge the rexus again. So this is one teaching here. Whenever you have a difficult situation, visibility makes a huge difference for a completion of surgery in a nice manner. So I've made around 4 millimeter rexus here. I'll do a phaco. Phaco is very simple once you do a good hydro procedure in these cases. I want to give you tips for doing a proper implantation of toric lens under the viscoelastic, and how to remove hooks, when to remove also. So I'll just complete my phaco here. So once I complete the phaco, I'll aspirate the cortex. This is our hybrid technique of aspiration. Little bit on this hybrid technique here, because you can use this technique here. So this is I think I'll remove my instrument. So this is the aspiration bimanual cannula. So I'll detach my aspiration tubing from my phaco handpiece, attach to the aspiration bimanual cannula without disrupting the antechamber pressure. It's very important for difficult scenarios. And irrigation on from the phaco and aspiration for side port. You can go anywhere and this will safeguard the difficult situations, especially subluxation also. Take out this, fill the bag, then implant the toric IOL. Normally what you do after you implant the toric IOL, because there is a viscoelastic cover, you like to remove the iris hooks first. So once you remove the iris hook, the pupil will constrict and the toric implantation may be difficult. What I'll do here, I'll remove the viscoelastic all around, fix the lens in a proper axis, then put the viscoelastic over the lens only. Then remove the iris hooks without disrupting the IOL position here. So this is image guided system, making little nicks in the capsule. This also is very important step in the smaller rexes, pseudo-explosion syndromes. These multiple nicks decreases the chance of phimosis happening in future. So these small tips are very handy in a small rexes cases. This enlarges the rexes and also prevent phimosis happening in the post-op period. I remove the viscoelastic from underneath. Now I'll put little bit of viscoelastic over. My lens is properly placed here. You can see these 3 dots here. Then I remove the iris hooks now comfortably and remove the viscoelastic subsequently. So this is how you implant the toric lenses comfortably in a small pupil where you have used the expanded devices. Remove the viscoelastic from underneath the IOL first, place the lens in a proper axis, then put viscoelastic over the lens, which you can remove subsequently without any disturbance also. So this is what you learn. Hexagonal appearance gives you a very nice appearance. Also it gives you a nice access to your emulsification, because these are 3 critical areas for your chopping and dislodging the nucleus. And injecting viscoelastic over the IOL, after you remove the viscoelastic from underneath, put the lens in a proper place and it can give you a nice access. I'll take you to the other case which I like to show you. The hard cataract case, sometimes they can be difficult here. So what I do here, after doing a proper capsulotomy and doing, this is at a different case, I'll go to other case here. Yeah. No. Only aspiration, because in the phaco you have an irrigation and an aspiration tubing here. So irrigation on, I'll detach the aspiration tubing, attach to the aspiration bimanual cannula. So irrigation all on through the phaco handpiece only, and in that process your chamber doesn't collapse. So you avoid coming out, going in and doing a bimanual also. So it's sometimes what happens, you have a thick epicortex, or sometimes you have little nucleus piece. This phaco handpiece on there, I can run the phaco also to decrease the, you can make a softer nucleus and take it out. It's very handy and it's very, very swift also. So this is a hard cataract hypermature case. You can do proper staining. Rexis, you all know, should be around, and toric implantation to be done around 4.5 to 5 millimeter rexis I'm doing here. So this is how we decrease the phaco load in these cases. This is a pre-chopping done by a MyLoop. MyLoop is a new technology which has come from JICE, and where we can crack the nucleus with the loop in 2 halves. So this is a MyLoop going inside. First you take it to other side under the viscoelastic cover. Make sure it goes right up to the edge. Once you reach the edge, then you turn towards the vertical side now. Once you have vertical area, you can stabilize the nucleus with the second hand and crack the nucleus in 2 halves. And this second instrument is very, very critical to stabilize the nucleus, otherwise the nucleus will tilt up. So once you do it, it chops the nucleus in 2 halves. It's a very hard nucleus. You can see a nice separation. I'll take out the loop, rotate the entire nucleus to the other side, take the loop again, you can chop it, so it gives you 4 pieces. So this loop gives you 4 times you can use this particular loop. So you can use for 2 cases, sometimes you can use for 1 case only to make a multiple halves. So this is a very, very hard cataract. I could make it 4 chops here. The idea here is to pre-chop the nucleus so that your effective phaco power is decreasing subsequently also. I'll aspirate the cortex here. You'll see how clean the chop area is in this case. Subsequently, I'll make the nucleus into multiple halves and chop it. So this is a very nice trick, and people should, if have access to this MyLoop. Requires a little bit of learning. This is my first case only. I could do effectively. It's not very difficult. Only thing, you have to have a complete rexis, good viscoelastic cover, and make sure the entire loop goes to a capsule rexis inside, and subsequently manage these cases also. So this is under a torsional emulsification, and you can see around 50 power. You can effectively do entire emulsification of a very hard and super hard cataract also. Subsequently, you can implant the lens and do a very nice toric implantation in such cases also. I think we are almost towards the end of our session. Any questions? We'd like to answer them. Gopal Raju, you are a good cataract surgeon, and you can express your comments. Yeah, this is the mic.
My loop looks little scary, and then so you're saying it's a first surgery. In Vityal's hands, it's maybe the first surgery. There's no learning curve, but in our case, I think definitely
you have to do a little bit of hands-on training, how to press that and how to go inside, and it's quite simple. And Dr. Manpreet has also done first case only, and it doesn't really only thing the rexus should not be very small. Rexus has to be around 5 millimeters so that you have a nice axis, and don't try to pull it back unless it comes to the middle. So once you go like this, you open and it should rotate, and it should. This was very dense cataract, could not see the posterior limit also. But sometimes a little lesser harder cataract, you can see the posterior reflex coming from the posterior part of a loop. Then you can just pull it. When you are pulling this loop, you have to stabilize the lens. Otherwise, the entire lens tilts up. So that should be avoided. People are using in our subluxury cases also. Only case where it is contraindicated a posterior polar cataract, where you have a chance of rupturing the capsule. I've seen 1 or 2 videos where capsule opens up before you do anything. Yeah.
It's actually similar to Anil Shah's snare technique.
Yeah.
The only thing in Anil Shah, you cannot do it in the back. You have to bring it over the back.
Actually, no, all these inventions are done by Indians, and people take advantage of this. I've seen this video in American Academy and AIOCMTC in the USA, where Arup Bhaumik from Desai Hospital, he started this snare technique. He modified his own way to do it. It was very effective. In fact, he won the best video award in AIOCMTC2. But Jai's people have taken a clue from there, and they have now patented this technique under them.
We do get these type of cataracts in plenty, so that may be the other reason.
Only thing is become a costly, it costs you an extra few thousand rupees per patient. Yeah, any questions from the house we are willing to take? We still have 5 minutes before we shift to the next session here. No questions. I'm seeing a young people sitting here. If I can ask question to some of them. Ma'am, you do cataract surgeries? Yes. So how would you protect your endothelium in a hard cataract, ma'am?
Only giving sufficient amount of visco, HPMC only.
Yeah, I can understand. Most people use SPMC also, and that's like a dispersive viscoelastic. Sometimes does give you help in coating the endothelium. Classically, we use dispersive viscoelastic, that is, like viscoat. Then put the cohesive underneath that to push the dispersive towards the endothelium, which is called soft shell technique of Arsenov. Very effective way, but even a methyl cellulose is quite handy sometimes also. Posterior polar, you have seen, man? No? Anybody here? Any questions? Young people sitting here? You do cataract surgery? You like SICS or Phaco? Young generation only Phaco. You have to do it. Thank you.
One question to Satyamoorthy sir. So now iris claw lens is more famous, or the popular, and then everybody is now referring iris claw, and in your hands it looks much simpler than the iris claw.
No, sir, the only thing with iris claw is it is a 2-point fixation.
Yeah.
It can wobble.
Yeah.
But advantage is that it is very fast and simple.
Technically less demanding.
Less demanding.
Yeah.
So this is just other ways of doing. It's like
Vityal sir.
I just asked question to Nuruban here, who's sitting here. Here is there. Like, we don't have experience of these lenses for a very long time. As I have seen my own cases where I fixated lens with these nylon, they have come out with a total subluxation. So these lenses, and even the Phacoemulsification, I have used various Phacoemulsification over the lens for a refractive correction, like very size. Those also they get iris atrophy, and the incubation gets detached. But sometimes they go through the entire iris tissue and they are like your nose clip. And I'm not sure this posterior the clip which is happening in the tissue, how much damage is going to cause there. Actually, it is the iris stroma, and slowly, slowly it will get pressurized, atrophic, and there will be a time it will get dislocated. So that part is a worrisome. If given to me, I'll never use for pediatric patients. I might use for an adult patient who are 70, 60, because the life of these iris stroma, I'm not sure how long they're going to actually have a support there, because ischemic atrophy happens in these areas. I don't know what is the...
Sir, it's better if it comes out.
Yeah, enclavation of this iris claw lens to the iris, when not done properly, first thing can result in an oval shaped pupil.
Yeah.
So it will be like a slit shaped pupil like what you see in an animal. And the second one is it can cause pigment dispersion. I have seen a case where there is an intractable glaucoma following iris claw lens fixation. That pigment dispersion syndrome, which was intractable, could not be managed with trabeculectomy, finally ended up on a GDD. Then third one is pseudophacodonosis. When the patient moves the eye, you can see that the lens keeps moving. So these are some three important, apart from that CME. So these are some issues of iris
and
claw
that
lens.
flicker which Satya was saying, sometimes these are not very stable, and that flicker can also give you visual disturbances sometimes.
I would like to make a comment on our iris claw IOLs. I've
Sure,
been
sure.
using them now for the last 4 years. So one of the things like ovalization of the pupil when everyone talks about. So few tricks for that for iris claw IOL is one, if we make scleral incisions of the side port instead of limbal incisions, we can get a more mid-peripheral enclavation that would avoid that stretching or a cat's eye kind of reflex that we get. Second, it is the pupil is very dilated when we are putting this IOL in. Again, that will lead to ovalization of the pupil. So using pilocarpine before we put in these IOLs would actually help in avoiding that kind of a stretching of the pupil. Third is the pressure that we put. So over a period of time, we learn that initially we are scared that we are not going to be able to enclave the haptic, the claw very well. So we tend to put more pressure, and that is when the claw actually comes on top of the iris. So if we are gentle enough, then we can avoid all of these complications.
Just for a young newer people, how do we know that we are going to have a proper incubation of enough amount of a stroma? What is the trick there?
So we look at just the dimpling of the iris tissue. So we are going in and holding it from one hand with the iris claw IOL holding forceps, and from the other side we can just use a hydrodissection cannula. We just need gentle pressure and look at the dimpling of the iris tissue, and we don't need a lot of stroma going into the claw. That will again lead to problems, and before we release, we can gently just pull on the IOL to see that we have achieved the enclavation.
Okay, good, very nice.
Thank
And
you.
while exchanging your hand, I mean,
Yes.
you incline the first one, then you have to change your hands. So
Yes, yes.
at
So-
that time, what do you do?
Yeah, so sir, we keep the IOL on top of the iris first. So you constrict the pupil. We have injected pilocarpine. The other haptic and the other claw is on top of the iris. Then we change hands. We put in viscoelastic and then gently put the other haptic under the iris. That would help. Thank you.
Thank you.
I have a suggestion. Instead of using that 26
Please come to the mic, ma'am. We have 30 seconds only.
we that Simsky hook is there now, we will straighten that hook and made it as a rod, and we used it for kinking of the tucking of the iris. Once you do that tucking full thickness, pigment release won't be there. We used to do iris class from the last 10 years, so it's very easy once you are master that technique.
That's
Very
great.
very
That's
simple.
great.
So one thing, when they are tucking, they don't know where the enclavation part is, because once it's under the iris, you don't know where it is. So one of the tricks what they say, the clover forceps is that it has two prongs, two sharp things. So when you're holding the lens itself, face that prong to that enclavation part. So when you see here, you know where to enclavate.
But I think it is the dimple which you create that tells you where exactly you are
So,
located.
sir, I think is talking about when you push the haptic under the iris, you
Yes.
don't know where the claw is. So, a trick for that is when you're using your iris claw holding forceps, when you're keeping it on top of iris, put the forceps exactly where the claw is. So, once your haptic goes inside, you know where the forceps are, and then you can easily just make a line in your head and then gently press it at that area.
Thank you. Yeah, a lot of experience in our retrofixation. We are for, we fix from front, Thank you for a very nice discussion. We invite the next session people. I can see Dr. Manpreet Kaur as a moderator here. Photo, yes, why not? Yeah. We can have photo. In the meantime, other people can take the chair.